thousands are raving about our best-selling 100 patient scenario book. And so we started creating the expansion books to go along with it, including the cardiac arrest scenarios, we have the airway scenarios, pediatric scenarios, and the MCI scenarios. And you can get this entire bundle at the link in our bio. This is MasterMedics. MasterMedics is an online learning tool made specifically for EMT and paramedic students. We've had 10,000 students come through us to transfer this textbook knowledge into their minds. And it works because it's fun, it's visual, and it's engaging. And if you want to try it out for yourself, you can start a 3-day free trial right now at the link below. And I think it's always important to kind of review these patients because you never know what's kind of been lost in translation over the years. And that's kind of why I wanted to go over this particular type of patient to help you kind of review some of these things. And so I know that opiate overdoses are fairly straightforward, but there's some important stuff to focus on. So let's get right into it and talk about these patients. Now, remember, if you've ever seen us before, or you've seen us here and there. My name's Geoff. I'm with MasterMedics. I'm the owner, and we have a whole team of paramedics that are building education for you all. And so, and that goes for particularly students that are going through school, that are trying to become paramedics, that are trying to get through your exams. That's our kind of our bread and butter of what we do. And so if you're interested, we would love to work with you there and kind of help you through school in a more visual way. That's kind of what we do. And so if you want, and check us out at mastermedics.com, and you can check us out with a free trial. See if the way that we approach medicine and education works for you, and then we would love to have you as a member of MasterMedics. And so before we kind of get right into it, let's do a quick little sound off of people that are here. So whereabouts are you watching from? Whereabouts are you watching from on social media? Go ahead, throw that in the comments. I would love to know where you all are from. Where are you all from? South Dakota? Whoa, where are you all from? Texas, Kosovo, El Paso, right on. Oh, congratulations, Alicia. Alicia, yeah. Nevada, South Texas, Canada, nice. It's my stomping grounds. Right on. This is great. Okay. So I think we got everyone here. You graduated with our program. Awesome. So glad to hear that, Valerie. Congratulations. Let's give you a little bit of... There you go. Congratulations, Valerie, on using our programs, getting through paramedic school. I truly appreciate you letting us know that. Hopefully you got your coin. If you have not ordered it yet, you can certainly still order for our coins that pass exams. That's what we do, is that when you pass using us, we send you a coin and congratulations. Okay. So here's the case. You are dispatched to a female patient who is hypoventilating and has pinpoint pupils. You suspect an opiate overdose. What treatment would you like to start with? Ventilations or Narcan? And so that's kind of what the direction I wanted to go with this. This is your patient on the bed, female patient, has vomited to the side and looks like her airway is clear. She has got snoring respirations as per the video. So that's kind of what we're dealing with. I gave you kind of the answer of what we're dealing with as far as the opiate overdose. So we can kind of get right into the treatments.
Unconscious patient who has vomited. You find her to be hypoventilating as well as have pinpoint pupils. You suspect an opiate overdose.
Okay, so that's what we've got. Now, just to quickly review how opiate overdoses work within the body, this is your synapse. And your synapse does a couple things. And so your fentanyl or your opiates are going to bind to a G-coupled protein here on the postsynaptic cleft like so, okay, on the postsynapse. And what's going to happen is a couple things when we have a binding of fentanyl. Is that first off, we have potassium channels that are going to open. So it's actually going to promote potassium to leave the cell. So it makes it harder for action potential to occur. And the second thing that it's going to do is that it's going to limit calcium to come into the cells like so, into the presynapse. Now, what does that do? Well, calcium has a pretty big role in the release of neurotransmitters. And so when we have less calcium, we have less release of neurotransmitters into the synapse. And so it actually decreases that that release. And so those are the two big things that it does. Now, what does this all translate to for you all is that what fentanyl is going to do when we have an abundance of fentanyl that's binding to these mu opiate receptors is that it's going to have a significant decrease on consciousness. It's going to have a significant decrease on motor function, and it's going to have a significant decrease on respiratory function. So a lot of those central nervous system functions that we rely on. So those are the big things. Now, we knew all the way back to EMT school what an opiate receptor or opiate overdose looks like, what it has, the reduction of those central nervous systems functions. But this is what's actually going on inside the body when we have an abundance of fentanyl or abundance of opiates that are binding to these opiate receptors that are going to limit the calcium influx, which is going to limit neurotransmitters, and that's going to also hyperpolarize the cell. Now, fentanyl or opiates like those, we use those for pain control, and this is the exact way that we use it. So fentanyl, if used within its ranges, is not is something that can be used for good when it comes to pain control. But when it's unregulated, when it's not being calculated, or you're not knowing what you're actually getting, then you can't really know the repercussions that are going to happen. And so an overabundance, an over concentrated amount of opiate receptors that are bound is not only going to create pain reduction, but it's also going to have a significant reduction of the central nervous system. Okay, so that being said, and knowing what's going on here, my question to you is really about the treatment. So we're going to get right to it. And so in the comments, go ahead and let me know, what do you think, or what is your process on an opiate overdose that is, not likely going to be polypharm, but you have an opiate overdose, and you are deciding what you need to do. What's your process? Do you start ventilations first on that patient, or do you go straight to your Narcan and reverse that opiate? Go ahead, put that in the comments. What is your approach to these patients? What is your approach? Ventilate first, then Narcan if needed. Emily Yeomans, my wife's maiden name is Yeomans. That's funny. I haven't seen that name in forever other than hers. Airway comes first. Ventilate, then Narcan. Vent. Ventilation first, suction, BVM, and meds. Okay. I like that. Definitely thinking about like the vomiting for sure. So suction's not a terrible idea to think about. What else are we thinking? I think we kind of all are on the same track, hey? Is ventilate first. Now, I tend to agree with you. Is that I typically will ventilate, and use my BVM if it's required prior to giving Narcan. Now, I don't like just saying this is what I do and then just ending the conversation there. And you might be wondering, well, why? Why do we use ventilation first? Not just because it's part of the ABCs, not because we always ventilate first, but why? Why do we do this? Well, the reality is that there's a physiological reason that we do this. Okay. And so one of those is that you have an abundance of CO2. So when you are hypoventilating, when you have a low minute volume, you accumulate CO2 in the blood. And so CO2 becomes a very heavily abundant gas. Okay. And when CO2 becomes an abundant gas inside your blood, it causes your pH to decrease. In other words, your body is now acidotic. Okay. So you are in a respiratory acidosis. And so by restoring ventilations with a BVM, we're going to allow some of the CO2 to get out and to be ventilated out, helping restore this pH. Okay, so essentially we're just restoring the homeostasis of the body by getting rid of some of the CO2 and helping restore some of that pH. So that's the first thing that ventilating first is going to do. Okay, the second thing is what it's going to do is that when you have these patients that are essentially in a decreased consciousness state, it has an effect on these vessels where the vessels are essentially a little bit more constricted. Now, that's fine, as it is, but when you give, say, your Narcan and you give it push, or you give it nasally, but you give a high concentration, whatever the case may be, you give the Narcan. Well, what happens is that you wake up the sympathetic nervous system. And when you wake up the sympathetic nervous system, it all of a sudden drives cardiac output. It rapidly increases it. So your heart automatically just starts squeezing more blood. And so if you haven't prepared the alveoli, if you haven't prepared the lungs for that, what happens is that you have an exponential amount of pressure within the pulmonary vessels. When you have a rapid increase of pulmonary pressure because your heart's sending blood to the lungs that it's not ready for, well, then you have a pressure problem that ultimately can cause fluid to escape into the alveoli, ultimately creating pulmonary edema. Now, is this a common thing? It is more common with higher doses or IV doses of Narcan because it creates a rapid introduction of a sympathetic catecholamines, okay, which creates the rapid increase of cardiac output when the lungs aren't ready. And so is it likely? Not if you're using the correct doses, but doses of Narcan vary widely when it comes to services. Not only is it vary widely, the route in which we give it varies. And so we have a very large disparity of it. So the likelihood of this happening is going to be very dependent on how we approach most of these patients. And you can avoid this by simply ventilating your patient first. So you're correcting two physiological issues by targeting the ventilations first and then using the Narcan. It doesn't mean that you need to ventilate them for 10 minutes or 20 minutes. I'm talking about up 2, 3, 4 minutes of good ventilations can be a big benefit physiologically inside your patient before you give the Narcan. So your partner could be just prepping the Narcan and you could be ventilating with a BVM, and that will be enough to help your patient physiologically prepare for that rapid catecholamine rush. So those are the two big reasons why I say ventilation first. And then once we have that all prepared, we have the body ready to receive the Narcan, then we can give it. Now remember that fentanyl is going to bind to these postsynaptic G-coupled receptors. Basically what that means is that it is stimulating that response or decreasing the response that I talked to you about when we had the potassium that's, shifting out of the cell. And same thing with the calcium is not being influxed in the cell to release those neurotransmitters. So that's basically what's happening. Now, what does Narcan do? Well, it competes with things like fentanyl and any opiates for these receptors. So you have, say, fentanyl that's coupled to these opiate receptors. Well, what Narcan is going to do is that it has a stronger affinity to these receptors. What is stronger affinity? It means that it's more attracted. It has a stronger bond. And the stronger the affinity, the more likely it's going to win out that receptor. So even though fentanyl or some opiate is attached to this receptor, because Narcan has a strong affinity to these opiate receptors, it's going to kick it out and bind itself, because it's stronger bonded to these receptors. And then once you have that opiate that is no longer bound to that receptor, then you have the reduction of calcium being able to influx. You have the shifting of potassium back into the cell. So that way we are starting to restore normal action potential and hopefully restore the normal central nervous system functions. So that is how Narcan works. Now remember is that Narcan has a relatively short half-life, and sometimes your Narcan can have a shorter half-life than the opiate that it's kicking out. So if it becomes to the point where it's been, 30 minutes of transport with these patients, it is possible that that opiate could still be available, and bioavailability means that eventually when the Narcan wears off, that opiate can now bind to that opiate receptor again. So it is possible that you may need to redose, not right away, but it is possible you may redose into the future because of a reduction of naloxone being available for its therapeutic use. So you may need to redose in the future when the Narcan starts to wear off. So just be aware of that. It's not likely, but it's possible. And so you see a reduction of the neurological symptoms again in your patient. It is possible that you might be seeing those opiate receptors being taken over again. Okay, so fairly simple and straightforward. Lots of pharmacology and physiology that was going on. Any questions that you have with this particular patient? Questions? Can it reverse carfentanil? Fentanyl? Yeah. So any of those more synthetic opiates. So cardenafil is I believe, to my knowledge, is either 10 or 100 times stronger than fentanyl itself. And so cardenafil has a really strong bond to those receptors. And it is possible that you would need significantly higher doses of Narcan, which has a slightly more affinity to them. But the way that cardenafil is that it has a really, really high efficacy. Basically, what that means is that it has a really strong impact on the body. It's really highly concentrated, is what I'm saying. And so it really packs a punch. And so typically when you have those types of synthetic opiates, you need higher doses and redoses of Narcan in order to impact the response that you're looking for. Another thing too is that Cardenafil is going to have the same symptoms, okay? And so it's going to create the hypotension and the decrease in the central nervous system. And so if you're having a problem waking this patient up or arousing this patient from giving Narcan because it's just such, there's no impact on Narcan because of whatever they took, then ventilation is going to be your best friend, because it doesn't matter what opiate it is, they all operate in the same way, whereas ventilation will be the main conduit to keeping this patient alive from going into an arrest because of a hypoxic event. So yes, is it possible that Cardenafil can limit the effects of Narcan and you're still stuck with a patient that is hypoventilating and in a bad state? Absolutely. And if you ever end up in that situation, don't panic, take a breath, and pull out your BVM and start treating this patient with ventilations and oxygenation. And you should be able to keep this patient from regressing further, because truly their big problem is ventilation. And regardless of what opiate it is, ventilation should highly benefit them, even if your Narcan fails. Good question. Yeah, there's a ton. There's quite a few different types of synthetic opiates. Like fentanyl was kind of like the first synthetic opiate, and now we're seeing a very large realm of them. What if the O2 sat is fine? Well, remember that this isn't just a hypoxic problem, this is a ventilation problem. And so you have a CO2 problem as well. So if your O2 sat is fine, can you Narcan first? You're probably going to have less of a bad impact or less of negative effects of it, but there's still nothing wrong with ventilating that patient first, even if they're good SATs. I mean, that's good news. You either caught them early or they ended up in a position itself where they're not hypoventilating nearly as bad. But what if their vitals are normal and they're not still waking up still? Then you might be dealing with polypharm or dealing with something else, right? So there's a lot of questions around, well, what if your patient doesn't wake up? Okay. Then you might be dealing with something else. So this is not an uncommon thing for us to deal with, where we're dealing with a patient that is hypoventilating, not rousable, and maybe possibly 2 mils on the pupils. That's not an uncommon patient. And then we go, okay, let's give the Narcan and see if we have an impact. And if we don't have an impact, then we start going down the path of what else could cause this altered level of consciousness. Could they have had a stroke? Could they be hypoglycemic? So basically what we're looking at here is that we're looking at a situation where if you do not see any positive impact on your treatment, then you shouldn't stop there. You should continue to ventilate, continue to divert, and kind of look at other things that could possibly be. And so if you end up in a situation where you thought this was an opiate overdose, you give your Narcan, no effect, and you're still ventilating this patient, you're like, okay, what the heck could be going on? Start thinking about what else can cause altered level of consciousness. Go through your go through AEIU and tips and start thinking about what could be possible and start looking at solutions. Is this hypoglycemia? Is this a stroke? Is this a cardiac event? There's lots of other things that can cause that. So just because your Narcan doesn't work doesn't mean that you're stuck. You just need to be thinking about other things that could cause the symptoms that you're seeing. Great question. Does Narcan have any impact on benzodiazepines? No, it does not. Benzodiazepines are a class in itself, which are going to have more effect on a GABA receptor, and GABA receptors are not connected to opiate receptors. And so Narcan only works and is competitive to opiate receptors. It has no effect on GABA receptors within the central nervous system. Good question. Whoa. Anything else? I don't think I missed any questions, but I'll stay on for just a couple more minutes to make sure I didn't miss anything. Do you think they will ever come up with something to reverse overdoses? Well, they do. Like that, we have the ability to reverse overdoses, but I'm not sure kind of what what your question kind of entails. We do have medications that reverse overdoses quite effectively, but I mean, pharmacology is an intricate thing. It's an intricate thing, and so when it comes to pharmacology, medications and illicit drugs all affect different parts of the body, of its receptors, and so on and so forth. So when it comes to treating overdoses, it becomes really tricky because not only do we have medications that will affect different portions of the body, which means that you need to create reversing agents that target those particular areas. That's the first thing. Second thing is that it's not always guaranteed that that medication is the only thing that they took. And so if they took several different medications, then all of a sudden you have several different receptors that could be affected. And on top of that is that when you combine certain things, and even combining it with alcohol, then you start to have potentially an exponential amount of efficacy, which means exponential amount of effect. So for example, cocaine combined with alcohol creates a whole other compound that can have a massive sympathetic effect that cocaine on its own does not. And so there's a lot of things going on with toxicology that I'm not prepared to talk about as a whole, because it's a massive topic that requires a much longer chat with this. But yeah, can we reverse a lot of them? Yes, but not all of them, and it also depends on a lot of different variables. Mm-hmm. Do you think the owner? Oh, I read that one already. I think I hit all the questions. Okay. Well, I'll let you go for now. And if you are interested, we would love to have you as a Master Medics member. So if this is the type of learning that you like, if you like the visuals that we use, this is the kind of stuff that we use inside our membership as well. So if you're a student and you're like, man, I could really use a different approach to learning certain things, we have a course that basically covers anything that's in the textbook. And so if you're struggling with something in school, there's a very good chance that we have a course that will cover it in a more visual way that can help you really kind of feel at ease and feel like that you're really learning the whys behind medicine. And so if you're interested, we have a 3-day trial. It's free. You can check it out. If it's for you, you can stay as you like. If it's not for you, you can cancel anytime. No problem at all. And you can continue to enjoy all the free stuff that we put out on social media. And that's a really good way of getting an idea of, what we're all about, is check out our social medias and see the kind of videos and content that we put out, and you'll get a pretty good idea of what you'll see on the inside as far as more longer form content that's available to kind of get a deeper understanding of certain topics. Okay, so I'll leave you there for now. Enjoy your weekend, everyone. I'm doing a class on toxicology and overdoses with our members on Monday afternoon next week. So if you want to check that out, and you can start up a 3-day trial, and that will cover your Monday, and you'll be able to attend that class as well. So we'd love to see you there. And see you next time. Bye for now.